I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is family medicine, guiding the way. Now, this is a live show, and we had something for the first time happen tonight where one of our guest could not log on due to restrictions from his Wi-Fi network at the hospital. So unfortunately, Dr. Sterling Ransone cannot join us tonight. He would join us in the next 20 to 30 minutes, but my goodness, we wouldn't want for him to be rushing from the hospital back home. We're going to reschedule having him come on at a future date sometime. My co-host and moderator of the chat is Dr. Dan McCarter. Dr. Dan, welcome.
Hey, Faisel, it's great to be here this evening. I know Sterling is very concerned that I'm sure he's very fretting that he wasn't able to make it, but I think it's safer for him and these patients for him to concentrate on them as a good family doctor, and we can have a little discussion tonight, and then we will get him back and give him the time that he should have.
Absolutely. This happened with me too. This has happened with me. When you go live, you just never know what's gonna happen. I remember we did the one episode with Dr. Grundy, Dr. Paul Grundy, and at the beginning of the episode, sure enough, my internet crashed and you all had to take off the show while I was trying to run around trying to get the internet working.
Right.
Well, tonight's topic is family medicine guiding the way. In particular, we're guiding the way from the fee-for-service system, which is a hospital-based transactional model, towards a fully capitated system where health is delivered even at the level of the home, but managed by primary care. And the topic is with family medicine. It just makes sense for family medicine to be the perfect specialty to guide the way to making that transition. And so I'd like to start this conversation tonight about talking about why I feel that it makes perfect sense. Dr. Dan, I don't know if I told you, I did my residency at an unopposed family medicine program in Columbus, Georgia, at the medical center. And so when we're talking about an unopposed family medicine program, that means that there are no other residents in that program. When you're doing your OB rotation, you're not watching an OB deliver the babies. You're the one delivering the baby. When you're in trauma, that's it. You're the one doing trauma. On medicine, we were the ones doing the admissions. And so when we're talking about making this transition away from what we have right now, pre-COVID, half of medical care in the United States was delivered in the emergency room setting. We have a very heavily hospital-based healthcare delivery system. And even if it's not being delivered in the hospitals themselves, the hospitals own a huge percentage of the practices, both specialty and primary care practices. So family medicine is right to make that transition because we were trained to provide complete care. We were trained to be the ones to do the prevention, to offer the early intervention. We were trained so that we wouldn't have to rely on specialty care unless you needed someone really to do for an intervention.
Right. And I remember one of my mentors, when I was a resident, was talking about family medicine was the one specialty that you could potentially practice without electricity if you had to. I mean, we still know the art of physical diagnosis and know the art of talking to the patients. Now, granted, during COVID, we've moved so much to the computer, but it's still about that relationship and being able to talk to the patient, to examine the patient. And the other thing that's important, especially I think if Dr. Ranson was here, he would comment on this, is family medicine, the specialty societies, really the only completely primary care specialty society at the national level. I mean, you certainly have a lot of primary care pediatricians and a lot of primary care internists, but family medicine is all primary care, and so he as the president of the AFP will really be taking the lead with that. So I think, and you're right, as you're moving to value based care, and it inverts the pyramid, right? I mean, people really think about the family physician, the primary care physician, as being the loss leader, the milk in the back of the store, if you will, for the fee for service. And when you turn to the value based care, then all of a sudden the primary care physician is the one with the relationship with the patient, one helping coordinate their care, one coaching them to make the better life choices, and then they suddenly become the most valuable commodity, specialty, if you will, and the partialists then become much less special as you go forward. So I think it's a great time to be a primary care physician, and especially if you are learning about managing risk and moving to value based care.
Yeah, in the fee for service world, what most people think when most people think of primary care, they think of wellness visits. They think this is a doctor that I go to get my medications refilled. This is the doctor that I go to get my referrals to go see specialists. I mean, that's what most people think of when they think of primary care these days in our fee for service system. And and really, and then when you think about prevention, when people think about what, if there's a medical emergency, or there's an outbreak, you think of public health. So public health is its own space. This, if you need a refill or a referral or a wellness visit, that's primary care. If you need active intervention, if you need to get an antibiotic or you've got pain that doesn't require an emergency room visit, people think of urgent cares. They don't think of primary care being a combination of all three of those. And in fact, we have primary care doctors who aren't they're getting trained in family medicine, internal medicine, especially with family medicine, and they're not even going into the outpatient setting. They're working in places like urgent cares. They're working in emergency rooms. They're working as hospitalists in the hospital. So it's almost like when making the transition to this healthcare delivery system that's based from the home, managed by primary care in a capitated way, it's like taking things back to the
Right.
way it used to be.
Well, but I mean, I've heard it said health doesn't happen in hospitals, and I think a lot of us, go into medicine because we enjoy science, we learn about the science, and but at the end of the day, if you've got, if you got sickness over here and complete health over here, well, the best you ever get in the hospital is about halfway to health, right? Because you don't leave people in the hospital until they get healthy. You don't put them on exercise programs, and you might do some diet teaching in the hospital, but that's a very artificial situation. It's not. I mean, I think today you were telling me about at one point you took a patient to the Aldi store to help them learn how to shop, right? I mean,
Well,
yeah,
there's more
yeah.
to that. There's more to that story, Doc. There's more to that story, Doctor Ted.
So,
I wanted to know where the patient was getting his groceries, and you know where he took me before the Aldi? I didn't tell you. He took me to the convenience store.
right.
He took me to a convenience store. Seriously, he took me to a convenience store.
And showed you how he was eating the low salt potato chips.
Yeah, that's what the situation was. I had to see
Right.
where he was getting it from, and I had to tell him he was on fixed income, like earning $500-600 a month in Social Security, and we had to literally. I had to see where he was getting his groceries. That explained a lot. So the bulk of his groceries he was getting from the convenience store, and then we went together. We went together to to the Aldi's, and actually, there's Aldi's pretty close by to most of our centers. And I got to see, I got to show him as well, and it changed his life.
Yeah. Well, and I mean, that's really about coaching for health, right? Rather than consulting for sickness, you were consulting for health or
And
coaching for health. I'm sorry.
that's right. Well, we've seen before. We saw it with the Camden Coalition. Saw with the Camden Coalition. You try to focus on the high utilizers. You focus on the high utilizers. You have all these teams of people. You've got social workers. You have different types of nurses. All different people who are there focused on the hot spotting, which was focusing on people who are frequently utilizing the emergency room or the hospital system. And the tragedy with that model, it showed that it was just ultimately that, hey, the medically complex are just too difficult to treat. But they didn't have a doctor, didn't have a family doctor, primary care doctor. Especially, I think family doctors are just perfect for that. Coordinating and helping lead that way, leading the care teams to help stabilize the patient population, look into what's going on here, because we know that a major chunk of what's driving all the costs in pathophysiology, it's lifestyle. More and more, the numbers are going higher and higher. First, I was hearing 60-70% of modifiable health outcomes are based on lifestyle. Now there was 70% and pushing even higher. Now some are even saying 80% of modifiable health outcomes are based on patient lifestyle. Well, who better than the primary care doctor to help drive the psychologists, the nurses, the care team members to help influence positive behavior change or provide the proper support so that people can live healthier lives. They can start stabilizing their lives.
Yeah. I agree. I agree 100%. And I mean, don't you think part of the issue is when the CPT codes were developed? And I mean, some really smart people came up with CPT codes, but there's not a CPT code for a relationship. And there's actually not a CPT code for keeping a patient out of the hospital. You actually get paid quite a bit of money for doing a hospital admission, but you really don't get paid at all if you're able to intervene and talk to a patient. I mean, this evening before the show, one of my patients had uh, um, texted me saying that she had fallen down in her driveway Sunday night, and she didn't know how to send me a picture or anything. And her son sent me a picture, and she's got a bruised arm, really swollen. And I was on the phone with him talking about what our options were, and I offered the options of going to an urgent care facility, or even if they had to go into the emergency room. But now that they want to come see me in the office tomorrow morning and have me take a look at it before we go somewhere else. But that's because we have that trust built up. But that trust saves somebody in the Medicare system quite a bit of money rather than what would happen if she showed up in the emergency room tonight. And now, I certainly don't begrudge. I don't want to restrict her access to the care, but she needs to have care that she's comfortable with and with somebody she trusts.
And who better than you to be the one who's coordinating all that?
Right.
And
Right.
how much time did that take?
And 10 minutes. Yeah, I mean, it didn't take long at all, and I let them know when they can come in tomorrow morning, and if we need to get an X-ray, we'll get an X-ray tomorrow, and then we will go from there.
Yeah, that there's no, if we try to explain to somebody in the billing model about the value of making a phone call,
Right.
and the response is, well, that phone call, you only get reimbursed $5, $6 for that
Yeah.
telephone call. Of course, there's very little to no value with the 10 minutes that you spent for that patient.
Right.
But had that patient gone to the emergency room, just imagine how much the cost would have been to the entire system, and we're all paying for it already.
Right.
I just heard Chris. We had a meeting in Orlando a few weeks ago, And
And when you say Chris, you mean Dr. Chris Chen, our
Dr. Chris
CEO?
Chen, our CEO, Dr. Chris Chen, our CEO. He was telling us all, we're like, this is a family business. We're all first name basis here, and thank God. I thank God for that. And he was talking about just the nature of the system. When you're talking about these large numbers, we're talking about billions of dollars, and now with healthcare, you're talking about trillions of dollars, $3.5 trillion, more than $3.5 trillion we spend on the healthcare delivery system as a country. And when you think about, post World War II, like there was one country that that United States was like at, during the Cold War, like we're at odds with. Whether you think about like intercontinental ballistic missiles, like the entire system, like this huge threat that to the United States was the Soviet Union. And now, of course, no longer Soviet Union, we've got Russia. But the entire GDP for the country of Russia is half of what we spend on healthcare in the United States. We literally spend more than double the entire GDP. That includes their national defense, all their infrastructure for their roads, their education, their entire economy, everything, their health, their health system. We spend double that on here in the United States for healthcare. And so when the costs have gotten so out of control and things have become so transactional, when we try to talk about, well, every patient getting a daily text message about some basic advice, basic medical advice, be careful, it's hot outside. Hey, don't forget to get your flu shot. These small little messages, and then a weekly phone call from the staff, what we call love calls. Where's the return on investment with that? What does that do for patients? I can tell you what that does for patients. Patients like my dad, who was at the center this morning, and he went to go see his doctor. 6 weeks ago, he fractured his right hip, shattered it. And today, he left the center without his walker. And it was a wonderful experience, wonderful moment. There was so much care coordination involved for him. Daily text messages, weekly phone calls, the doctor FaceTiming him, checking on how he's doing. All that coordination was happening with the therapists from 2 different states. The accident happened in Texas. They coordinated everything so that his therapy didn't even skip a beat. They knew when he was coming back home so that the therapist could be over there in Tampa to continue on with the care, so that he could just focus on recovering from that horrible accident. And even me, as a doctor, I didn't have to worry about any of the doctoring. All I had to be was his son. And so where's the return on investment with all those phone calls and the FaceTime? I mean, that situation, when you get into an accident situation, when you're in a situation like this where you're completely dependent on the healthcare delivery system, it should not be an opportunity for the healthcare delivery system to say, oh, all right, here's our opportunity now that we can really generate some revenue from this situation. It shouldn't be like that.
Right. Right. I don't know how we actually make the conversion. It's interesting. I've got a quote that I want to read you, but I was wondering, do you want to do the commercial break and then come back and do the quote, or do you want to?
Sure. Let's take a quick 20-second break. We appreciate anybody who's listening to us. It's just Dr. Dan and I talking our usual shop. Obviously, we're very passionate about primary care, especially family medicine. So we'll take a quick 20-second break, and we'll be back to hear this quote from Dr. Dan.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. It really was 20 seconds.
That's right. So no, I ran into, Adam Grant. I think we both read some of his books. He's an organizational psychologist. And he saw this quote on LinkedIn this morning. And I first thought about it as an individual but then think of it about the health system. And his quote was, "It takes curiosity to learn. it takes courage to unlearn.
Mm,
Learning requires the humility to admit what you don't know today. Unlearning requires the integrity to admit that you were wrong yesterday. Learning is how you evolve. Unlearning is how you keep up as the world evolves. And
wow.
so if you think about this as healthcare, don't we have to unlearn fee for service? I mean, and I don't know how we do it as an organization. So many people are getting paid to do fee. I know primary care and family medicine needs to lead the way, uh, but we've talked about a lot of smart people getting paid to work in a dysfunctional system. How do we get the system to change around us?
Well, it's well, at least from the medical side, there's a massive mindset shift that must occur. For the doctors, I mean, we're all trained to think in terms of the patient's chief complaint. So if the patient comes to you and the patient's got a chief complaint of, say, low back pain, but meanwhile, they've got COPD and they're in between COPD exacerbations, still smoking, and you spend, well, the chief complaint is low back pain, and you go through the history of present illness, and you say, patient, so and so year old, whatever, male, female, is here with complaints of low back pain that started at this time. This is what makes it better. This is what makes it worse. And you go through your entire review of systems and your physical exam. You get down to your assessment plan, and you're just focused on that back pain. And there you go. You spent your entire visit. Of course, with your physical, you're doing everything with your back, and you've done a fantastic job of addressing the patient's low back pain. And meanwhile, you didn't have time to talk about the smoking. You didn't have time to talk about your concerns with being the doctor, the patient's COPD exacerbation. And we feel like we did a good job. I lived that system. I mean, I've done that. We've all done that. And we feel good trying to help someone. This is a serious concern. Patient's chief complaint is obviously a major concern. We want to help alleviate their concerns. But should that consume the entire visit, especially if you're only talking about having one or two visits with your doctor per year?
Right.
I don't think it should consume the visit. I think that I think there's a reason why many urgent cares are called these minute clinics, and many of them aren't even staffed by doctors. There's a reason why, because many of these concerns can be the minute clinic visit. We still address the patient's chief complaint, but then making that focus, the shift in the focus, that, hey, I understand this is your chief complaint, but let me tell you as your doctor what is my primary concern. You're in between COPD exacerbations. I'm worried about you. One of these exacerbations, if you continue doing what you're doing, could end up being a life or death situation. That mindset shift, that has to happen. You can't talk about changing the entire system if we still practice. A lot of what we have to do with doctors that come join the full risk model is actually help them. It takes a lot of coaching to help them shift in that mindset. They're used to writing. Doctors are used to spending 20 minutes documenting each patient encounter, which makes sense if you only see the patient once or twice a year. But does it make sense in our world where we see the patients on a monthly basis? Some of them routinely twice a month. Absolutely not.
Right. But then how do you help them with their habit? Like your story, and of course I'm switching diseases here from COPD to diabetes. Is I remember the story about you asking the patient to cut their Coca-Cola
Oh,
consumption in half. I mean, you told them they could keep drinking Coca-Cola, just drink half as much. But I mean, people, I think it was Mark Twain said that habits are to be coached down the steps one at a time, not flung out a window. But so often we think we've done our job. We say, quit drinking Coke, quit smoking. And if you don't do it, you're non-compliant. And if that were true, I mean, how many of us have perfect health? All of us can make changes, right?
I was that doctor. The diabetic would come. I'd say, okay, no sweets, no rice, no bread, no pasta. That we had our things that we would say, and the patient's kind of looking at you. And meanwhile, you refill the medications. Patient comes back whenever the patient comes back, and I feel like, okay, I did my job. patient, no sweets, no rice, no bread, no pasta. Uh, but to really meet the patient and say with the patient with the diet, the soda, it took a conversation. And actually, we didn't talk about the soda raising his blood sugar. He knew that already. He didn't need me to tell him that that the soda was raising his blood sugar. But what we talked about, what we connected on, was the cost. I suggested to him, rather than drinking a can of buying these cans of Coke, you're living on, I remember it was like $500, $700 a month in Social Security per month. And I said, rather than spending all this money on individual cans, why not buy a 2-liter bottle of Coke at a time? And his response was, he said, well, with the cans, every time you get the fizz. You get that same experience with the big bottles. You lose the fizz. But we connected on that, actually. That was what we connected on. And I said, well, would you be opposed to, when do you absolutely need to have that soda? And he said, well, Doc, it's Tampa. It gets hot here. I absolutely must have it with my lunch, and I got to have it with dinner. And I agreed to him with that. And I said, okay, well, if that's when you absolutely must have it, could we substitute the other times of the day with seltzer water? And then you could add the 0-calorie, any flavoring, and as much as you want, you could add to it to make it like an orange soda or whatever, a fruit soda or any of that. He agreed to that. And immediately his blood sugar started crashing. He called me complaining that his blood sugar was crashing and he had to drink something to raise his blood sugar. And so we weaned him off the medicine. We weaned him off the medicine. It's one of my favorite things to do at ChenMed was the inappropriately diagnosed insulin-dependent diabetics. People who've been they go to the emergency room. They get diagnosed with diabetes in the emergency room setting. They get prescribed insulin, and then they leave from the hospital with an insulin prescription. And even if they can't, when they go see different doctors in the outpatient setting, they just show their insulin vials. They show the box saying, "Hey, this is what I'm taking," and none of the systems are talking with each other. So whoever is seeing, I say, "Okay, well, here, you refill the medicine because I got to refill your meds, and we're going to order some labs. God knows if the patient's going to get the labs done or not." And but we did our job. We refilled the medicine, and we have patients who've been going through that cycle of just getting these medications like insulin prescribed to them by different people, multiple different people, sometimes for decades. And so I laugh when I tell the story about the patient who was able to, and actually he ended up stopping drinking the soda altogether and just switched completely to seltzer because it's much more cost effective and it tasted better, much more stronger. Actually, the fizz in seltzer water. If you're listening and you know somebody who's addicted to sodas, it doesn't matter what brand of soda, but if they're addicted to sodas, offer them the seltzer water with the 0-calorie flavoring. You'd be surprised. The blood sugar is going to start dropping. But that's what it took. It took building a relationship with him, trying to meet with him some way. It wasn't just, hey, no sweets, no rice, no bread, no pasta, and that's it. And I'm a great doctor. It was actually just meeting them, and then also having the team too. The team supported me. They gave me a heads up before I went in there, letting me know that this patient's seen multiple doctors. It just wants me to refill the medication. That's it.
Right. And a lot of it is having that relationship. And, I know that we went here at ChenMed somewhere from a flu immunization rate in 2016 below 50% that we really weren't very proud of at all till 2020. We were up in the 80% range. But the really cool thing was then when the COVID vaccine came out and our very high need patients that were getting very, very hit hard by the COVID in these neighborhoods, our patients, because they'd taken the flu shot, were twice as likely to take the COVID vaccine.
That's right.
So, having that relationship, and when people start making one healthy choice, they will start making more healthy choices. And so just having Having people have the personal commitment, consistency, and will do that, but it's really about that relationship. And I'm so hopeful that family medicine and primary care is going to be able to lead the way. This isn't new evidence that primary care gives better outcomes at lower cost and lowers mortality. I mean, those studies have been out since the early 1990s, if not before. And, the National Institute of Medicine talked about crossing the quality chasm and the importance of primary care. Finally, the new NASM reports now talking about implementing primary care. And so it's not enough just I think in the past they thought it was good enough to say how important primary care was and let smart people do the work. Now they're actually making a proposal for how to implement a high quality primary care. And obviously, family medicine is going to help lead that way. And certainly, we have a lot of great primary care physicians, family doctors, general internists, uh, um, uh, uh, geriatricians at ChenMed doing that. And we also have a number of cardiologists. And when I first met Chris Chen, he said, "Yeah, I'm a primary care physician. I know a little bit more about the heart than the average primary care physician." The I don't know, quadruple boarded cardiologist that he is, but he still views himself as a primary care physician. And his favorite thing to do is to talk people out of eating fried chicken to decrease their risk of heart failure.
Well, Dr. Dan, tonight, I thank the audience who were able to join us tonight, and I'm glad that we were able to at least have a conversation about family medicine. We're obviously both very passionate about family medicine, and with family medicine leading the way from this hospital-based transactional model to one that can be delivered at home and should be fully capitated and managed by primary care doctors.
Absolutely. Yeah. Relation based, not transaction based.
Yes.
Yes.
So for more information about tonight's topic, as well as to explore career opportunities with ChenMed, remember, we're on track to open another 500 centers across the country. When I look at where we're going even next year, I'm just completely blown away. Each center, you're talking another 4 to 6 doctors. So you're talking another 3,000 plus doctors, along with all the care teams to support them. If you have any interest, please visit chenmed.com. We believe access to primary care is a right, not a privilege.